So I welcome you all. Good morning, good evening, and good afternoon to all the speakers, all the delegates, all the moderators and friends from different parts of the world. And I welcome you all on behalf of ACNS-YNS and on behalf of Professor Yoko Kato for this yet another monthly education webinar, especially for the young neurosurgeon and especially for the young neurosurgeon from the low resource countries. And this particular episode is dedicated to the education of neurosurgery in Afghanistan and Central Asia. And for that, we have chairperson, Professor Fawad Pirzad. I'm so happy to see him after so long time. I wish him great health and I wish him be with us for more and more webinars. And Professor Yoko Kato, who is our patron and our support there. For today's particular episode, we wanted to specially focus on the anatomy aspect for the young neurosurgeon, as basics are very, very important. So considering that point of view, we've got Professor Igor Maldonado from Brazil with us, and Professor Kosumo Noda from Japan with us, who's going to talk us about anatomy and about the aneurysms. So I welcome you all. I would request Professor Fawad Pirzad and Professor Yoko, first Professor Yoko Kato to say a few opening words, and then Professor Fawad Pirzad, and then I'll ask Ben to introduce Dr. Igor, and we'll go for the first talk. Professor Yoko Kato, could you please say a few words?
Yes, thank you very much. So we are so happy because we are so sorry because it's very less number today because some people is traveling to the border and some just we finished our webinar, so maybe they're some having some rest, I think. So in a few minutes, I think they will be gathering. So we are very honored today. The two big person. One is Dr. Igor. He's very famous in many fields, especially the anatomical viewpoint. And also Cosmonoda is still, you are just 33? How old are you?
No. I'm 45.
Sorry. You look very young. So anyway, they're still very young. So, but he is a very good technique of especially the aneurysm and also the bypass surgery. So maybe the participant can learn a lot from them. Please start. So, Pirzad.
So may I introduce Professor Igor Maldonado? So he's the professor of neuroanatomy in the Federal University of Bahia in Brazil, and he's currently working at the Tours University Hospital and Eyebrain Laboratory in Tours in France. So he's also one of the members of the International Academy of Neurosurgery and Anatomy. So today he will present the topic on the nose as a neurosurgical corridor with a cadaveric dissection. So may I invite Professor Igor for his sharing.
Thank you very much for the introduction. I see that Professor Pirzad wants to say something, but I think his micro is not working.
Yes, thank you very much. Hello, hola, gracias, arigato gozaimasu. Thank you very much for you and Professor Kato and Professor Sachin and Professor Cosmo Noda and Igor. Thank you very much. Thank you for this opportunity for us and for low and middle income countries like Afghanistan. This is a great opportunity for Afghanistan neurosurgeons and young doctors, and we appreciate your works and say thank you on behalf of young neurosurgeon from Afghanistan, and this is great to see you and hear and know your presentation. As you know, this in Afghanistan, this only the classic way to approach to the brain through the craniotomy. And the nostril as a corridor, it's new and for Afghanistan neurosurgeons. And be glad to, through your experience, find a way to the advanced neurosurgery. And we wish some of our colleagues, young colleagues, going to for training in advanced neurosurgery. Thank you very much. Arigato.
Arigato.
Yes.
Thanks, Professor. So shall I start?
Yes, Professor, you can share your screen and start your talk, Professor.
You see the opening slide?
Yes, I can see it.
Okay, thank you. So first of all, I'd like again to thank for inviting me. It's always a pleasure to participate to Young Neurosurgeons webinars, ACNS webinars, and even more pleasant for me when it's about anatomy, because you know I love neuroanatomy very much. And today we are going to discuss the nose as neurosurgical corridor, and I will show you the results of some cadaveric dissections. I will stop my video just because my internet's not very good. I will keep the audio for the moment. And then we'll see the main anatomic elements for these approaches. In many ways, the structures we are looking at, mainly the structures of the intracranial stages, they are the same structures we are used to see in cranial neurosurgery, but the perspective is different. The angle of view is different. So I will show you the nose as the corridor, and then the results in the intracranial space at the end of this lecture, according to the direction of the endoscope or the angulation of the endoscope. And then we will see how we can didactically subdivide the different structures inside the cranial space, and to build our mental image and know what we are going to find when we perform this kind of approach, mental image that will be built because of anatomy. Well, operating on the skull base through the nose is like looking after a long corridor. Let me tell you a small curiosity. The tourists in the periphery of Rome, they discovered that looking at the specific keyhole, a correct keyhole in one of the gardens with the Knights of Malta gardens around the city, you get this magnificent view to the St. Peter's Church, which is a very touristic site. But you need to look at the church through this very long corridor of trees. And then if you cross that door and you enter the corridor, your field of view changes, it widens. And then you see more and more the places, the structures that are around. And finally, when you get out of the corridor, you see everything which is around and that you can visit. So using the nose as a surgical corridor is like visiting the St. Peter's Church. When you get closer and closer to your target, you are less and less obliterated by these lateral structures. And actually, you see, you have more freedom because you can look at the sides and you look closer to structures that, as neurosurgeons, we're not very used to look at. And endoscopic neurosurgery, the anatomy for endonasal approach is not only a change in perspective, it's also a change in concept, because we were looking at the structures that we are not used to. And one of the main reasons why we may consider that we tend to be more aggressive with endoscopy than with microscope is because of this flexibility, because we are looking at the structures, at more structures, and you can look to the left, to the right, and then work with anatomical structures that we did not use it to do in the past. It's also a matter of illumination, having the source of light close to the target and not outside of the corridor eliminates almost all the shadows. But you have some what we call barrel distortion, as you see here, because of the anatomy of the lens itself. Well, so let's get into the nose, such as we got into this corridor of trees in Rome. So when you look at the drive school, when you look into the nose, you see that you have the nasal septum, which is made up superiorly by the perpendicular plate of the ethmoid bone, inferiorly by the vomer. Of course, in the living person, in the patient, or in the fresh cadaver, you also have cartilage for the anterior part. And then when you look laterally, you see the inferior turbinate, the middle turbinate, and usually you don't see the superior turbinate, which is very far away, but we see a little bit in this specimen. And lateral to all those turbinates, you have the meata, the inferior meatus, middle meatus, and superior meatus. And you see that in the middle meatus, you have this prolongation of bone, which is in antero-posterior direction, which you also see here in this ethmoid bone, which is called the uncinate process. And the uncinate process is taking some space in this cavity and is partially covering a prominence of the ethmoid bone, which is just behind it, which is the bulla, the ethmoid bulla, which is also aerated. So you have finally a very narrow space between these bone structures, which is called the hiatus semilunaris, or semilunar hiatus. And this hiatus semilunaris, you will find the foramen of the frontal and maxillary sinuses. Well, these are structures that may be removed for extended approaches to the skull base. Well, if you look up, you see that the space here is narrower, much more than the space you have in the lower portion of the nasal cavity. And it is particularly true if all these structures I showed here are preserved. If you follow the roof of the nasal cavity, you get to the anterior skull base, the plano sphenoidale, and then to the anterior wall of the sphenoidal sinus, then inferior wall, and then the clivus. And then you pass by the opening, this opening that you also see here, which is the choana. So we were looking at the superior edge of the choana. It means that if instead of following this, which would be much more difficult because as you saw, the space is very narrow, you follow this space here in the lower portion, it means you keep medial to the inferior meatus, it will take you directly to the choana and to the posterior wall of the pharynx. Oh, something happened with this slide. So let's take a look at the septum. In this dissection, you can see the relationships between the sphenoidal sinus and other elements of the skull base. So you see that the ostium of the sphenoidal sinus opens lateral to the, medial to the superior turbinate. Actually, you have here a very narrow space, again, which is called the sphenoethmoidal recess. And the sphenoidal ostium opened in the upper portion of this recess. We also note that this ostium is approximately located in the transition between the upper third and the middle third of the anterior wall of the sphenoidal sinus. It means that if you approach the sphenoidal sinus, enlarging this ostium will be working much closer to the anterior skull base than to the posterior skull base. And we also see that a third to a quart of the clivus is related to the sphenoidal sinus in this case, although it is very variable because you have sphenoidal sinuses of different sizes, and all the rest of the clivus will be below it. We also see, when you look at the septum, some reliefs here, and here. Those are vascular reliefs, vascular prominences. So what we are seeing here are the prominence of the sphenopalatine artery, which is coming to vascularize the nasal septum, coming from the pterygopalatine fossa. Actually, the posterior and lateral wall of the nasal cavity is made up of a palatine bone, as you see here. And the palatine bone is made of a horizontal plate, which forms the posterior portion of the hard palate, and a vertical plate. And the vertical or perpendicular plate of this palatine bone bifurcates in two processes. One is to connect to the orbit, and the other one is connected to the sphenoid bone. And in between, you have an orifice, you have an hiatum, and this is the foramen. This sphenopalatine foramen is the foramen for the sphenopalatine artery. Usually you don't see the foramen, but you may see the artery pulsating because it's really close to your working zone. Once again, we see that if you follow the floor of the nasal cavity, or the angle between the floor of the nasal cavity and the septum is going to take you directly to the opening of the choana. And then you see the opening of the tuba, the torus tubarius. And look that when hard palate is finished and you're dealing with soft palate, the inclination makes that your field of view go actually very inferiorly up to the level of the oropharynx or even the upper cervical spine. So this is anterior arch of the atlas and odontoid process. Let's take a look at the next. In this picture, we see that a sphenopalatine artery was exposed. It gives a long branch for the posterior and inferior portion of the septum, and the anterior-most portions will be irrigated by a mix of sphenopalatine artery and also branches coming from the ethmoidal arteries, an anterior septal branch from the anterior ethmoidal artery, and then branches of the posterior ethmoidal arteries. And these anastomosis are particularly important in the anterior portion of the septum, where you found anastomosis with labial arteries or palatine arteries, and it's called the Kieselbach area. It's an area that is particularly prone to hemostasis. It is exactly where we do compression in cases of spontaneous epistaxis. If you look now at the lateral wall, you see relationships of the turbinates and all the structures we are discussing and the orifices. So again, inferior turbinate, inferior meatus, and I follow the angle between the floor and the middle and the septum, and I will be taken to the opening of the choana and to the posterior wall of the pharynx. Then I see the relief of the tuba, the torus tubarius. So where is the sphenopalatine artery here? The sphenopalatine artery, I don't see, but I know that it emerges very close, immediately posteriorly and superior to the attachment of the middle turbinate. So this is the point of emergency of the sphenopalatine artery. You see this prominence, it is often seen in the anterior portion of the nasal cavity. This corresponds to the prominence of a nasolacrimal duct. Then in the middle, turbinate. This particular case has a large medial meatus, You see two large orifices. One is for the frontal sinus, the other is for the maxillary sinus, and some ethmoid cells were open here. So you see ethmoid cells are open, and then you see the superior turbinate and this narrow sphenoethmoidal recess I mentioned with the ostium of the sphenoidal sinus in the upper portion of this sphenoethmoidal recess. This dissection is also interesting to see the relationships of the sphenoid sinus with the clivals and with the intracranial structures such as brainstem, and also how your field of view can go, if necessary, relatively inferior up to the inferior clivals or superior portion of the spine, cervical spine. So let's take a look at the right nostril. So we see inferior, middle, and superior turbinate. The septum is here, and the opening of the sphenoid sinus in the sphenoethmoidal recess. Then let's elevate the turbinate medially, and we see covered by mucosa the uncinate process and the bulla. So we are looking at the hiatus semilunaris, or semilunar space of the middle meatus. These structures can be seen in a CT scan. These are bone windows. So, and this is a parasagittal slice. We see the inferior, middle, superior turbinate covered by mucosa. The anterior skull base, the cubiform plate will be here. And of course, it's sphenoid sinus. Here you see how the I have the bulla and ethmoid cells and uncinate process interposed between my approach and the lateral wall of the orbita and the lateral wall of the maxillary sinus. So it's explain how the extended approaches to maxillary sinus and the orbita they include the step of removing of all those structures. It's very important to note that if I remove here, I'm completely in contact with the orbital cavity and the maxillary sinus cavity. I will be separated from the orbit by a very thin layer of bone, which is called the lamina papyracea. Another important concept I would like to emphasize is that the cribriform plate is much narrower than the lower portion of the nasal cavity. Actually, this plate is also in a level which is inferior, is lower in relation to the anterior skull base. Actually, if you develop an approach for the anterior skull base at this region, when you remove all these structures, actually, you are enlarging your approach laterally. You are not dealing with so narrow space anymore. We are dealing with the whole width of the nasal cavity. So remember that the nasal cavity is narrower in the superior part, is larger in the inferior part, and widens also posteriorly when I get to the choana and to the nasopharynx. And if I want to progress my endoscope, if I'm lost in the nasal cavity, nice trick is to find this angle between the floor and the nasal septum, and I follow this. I'm middle to the inferior meatus, and this angle will take me directly to the choana and the oropharynx. If you look up, the space is much narrow, and you see the border of another structure, which is the middle turbinate now. And you see how narrow is this space here. As you see, and this is a video, and you see the space is narrow there, is large and below, and you go straight to the pharynx. If you look up, you know that your sphenoid sinus will be there. If you look down, you see the torus tubarium, so the Eustachian tube. And also you understand this anatomy, you can open the sphenoid sinus. And in this case, we dissect first the mucosa, and then we see the attachment, the suture between the sphenoidal rostrum and the vomer elysis. So you see the bone suture here and here at both sides. And then we widely open the sphenoid sinus to see structures. Some of them are structures that we already know from the intracranial space, some others are new. So first thing is try to recognize structures from midline. So this was a very wide exposure for anatomic demonstration. So in the midline, the first thing I recognize is the sella. I see the prominence of the sella, then the planus sphenoidale and the cribriform plate. You see there is already still some olfactory filamenta. And then if I go now inferiorly, I see clivus. So this is the infrasinusal part of the clivus. And then I have the part of the clivus, which is outside of the sphenoid sinus. And then if I look lateral, I see two prominences of each side. This one, the left one, is more marked, which corresponds to the paraclival carotid. If I follow the carotid to the intracranial space, I don't see the upper portion of the artery yet because the bone was not yet removed, but I know that will be continuing with the intracavernous carotid, then paraclinal carotid, and then intracranial subarachnoid ICA. Also, there is an important accident we see here with endoscopists like very much is the optic carotid recess, optical carotid recess. Sometimes you have a second one, a medial optic carotid recess, but this is the most important one. And it just below to the optic nerve, you see here. So it means that this is optic canal. This is the sella. We know that carotid will be there. And this part corresponds to the projection of the superior orbital fissure. It means that if I have a cavernous sinus here, the nerves will be coming to the superior orbital fissure. This is optic canal. In between then, let's try to remember the structure you have on the other side. This is the optic strut. So this corresponds to the optic strut in the endocranial aspect. So let's remove bone and see what happens. So I see the dura. Now I can follow more easily the artery. Everything is covered by dura. I have to keep in mind the dura mater is made of two layers. One layer is periosteal layer, and the other inner layer is meningeal layer. And the cavernous sinus is made of these layers. But when you are at the level of the medial of the cavernous sinus, you don't have periosteal layer. You only have a meningeal layer. It means that the medial of the cavernous sinus will be practically made up of the dura sac of the gland. So it means that you have a very little tissue between the artery itself and the gland. And as I told you, superior orbital fissure will be there. Then you see nerves that are running. So this is third nerve, oculomotor. This is sixth nerve, abducens. And then you have the optic nerve that was exposed and the relationships you have with intracranial space and brainstem for more extended approaches would be outside the scope of this specific lectures. Then we just dissected widely from very anterior to very posterior. So you see all the power of this approach. You can go up to the very anterior skull base, cribriform plate, planum, sella, and then if you look down, clivus, and this is the C0C1 space. So in the midline, it's extremely flexible approach. And then this is my last slide. This is a didactic subdivision of the intracranial space through endoscopic approach. I like very much, was published in 2004, I think, by Cavallo and co-workers. And it divides into 4 zones: 1, 2, 3, 4. Zone 1 is what you see when you open the anterior skull base, and then you have access to the basal frontal lobes and olfactory tract and the lamina terminalis. It is, zone 2 is what you see when remove bone around the gland itself. If you remove the tubercle of the sella and the posterior clinoid, you have access to the midbrain pontine transition vessels and nerves. And zone 4, you have access to the ventricular system and to the supra pituitary space. So that's what I wanted to show for this anatomy. Again, thank you very much. I hope it was useful. I will stop sharing my screen. Thanks again.
Thank you very much, Professor Eager. That was indeed an excellent presentation and very orientation talk of basic anatomy of the nasal corridor. So the floor is open for the discussion. Any questions from the delegates? Dr. Chen or Dr. Ben?
Yes, Professor Igor, thank you for your presentation. It's a very great review of the nasal anatomy. I have some questions concerning the nasal anatomy. The first one is about the role of the posterior clinoid. So during this extended transsphenoidal approach, when will you consider drawing of the posterior clinoid, and by drawing it, what views will you get? What is the benefit of it? And also, when you drill the posterior clinoid, would you go transcavernous approach for the drilling? The second question is about the maxillary stroke. So how do you approach maxillary stroke during extended approach, and what is the role of it during the extended approach?
Thank you. So those are not very common approaches. For the posterior clinoid, when you remove the posterior clinoid, you can, of course, very delicately and carefully displace the gland. You can elevate the gland, move the pituitary gland, and get some view to the upper posterior portion of your approach. So it means that we'll be exposed the midbrain and superior pons region, and you see the intrapeduncular fossa and the P1s and the part of the posterior communicating artery. So you have access to all this region. But again, it's not something that is really frequent. What was the second question? Sorry, I didn't understand your second question.
Yeah, the second question is about the maxillary stroke. So I saw in one of your pictures, there's a label of the maxillary stroke. So usually how would you consider drawing of the maxillary stroke? And
maxillary structures?
Yeah, maxillary stroke.
Optistruct or maxillary?
Maxillary.
Maxillary, okay. This is for, and I'm not, the expert on this. Again, this is not very common in my practice to do this. But when you extend laterally, you remove those structures that I showed in the middle meatus, middle turbinate, and then you extend it to the maxillary sinus. You can more easily expose, what the section was in one of my last slides. You see a wider exposure of the carotid, and you see abducens nerve and more lateral situated structures. So when you want to go really lateral, you need to open this. Otherwise, you don't have angulation for your endoscope. If it's for pathologies that are in the midline, or if you're going straightly go to the pituitary gland, there is no need of it.
Thank you. I have another question. Is in your dissection you show the optic canal and the laminar preparation quite nice. So in real life I want to ask Professor Eagle or other members in the panel that for the endoscopic decompression of the optic nerve in the trauma. So would you because it's quite controversial. And do you have any experience or other members in the panels have some experience in about the indication? So when would you consider the endoscopic optic decompression in a trauma setting?
In the trauma setting, for the decompression, I have no experience of the decompression of the optic canal through endoscopy in trauma section. What I would imagine that if the goal of your decompression, if the aggressing fragment of bone is much more accessible inferiorly than superiorly, for me, I would maybe consider endoscopy. But again, I've never done this. It's just conjecture. I don't know if one of the members of one of the panelists have some experience on this.
Can I talk?
Yeah.
Yeah.
When you do the decompression for optic canal when the trauma, I have not so much experience, but there must be some brain contusion, something in the skull, on the skull. We have to go from the open surgery from the skull. And in the face, if there is the trauma, I think it must be very difficult from the nose. I think something happened in the face. I don't know, but
there is something that is we must mention is the risk of such procedure for complication, because if you there are two elements I would like to emphasize. One, if you were dealing with a skull base fracture, anterior skull base fracture, so probably you may have fistula, and it may not be the easiest way to deal with the fistula coming from below. In the setup of a severe cranial trauma, you may be more efficient from a cranial approach. And the second point is that if you are in this setting of cranial trauma and you're still coming from below, you're going to drill very close to the carotid. There is one complication, even though it's not very common, but is very frightening, is carotid damage, carotid dissection, and carotid pseudoaneurysms, which may not be intraoperative. I have been some. I have seen some. I have never had with one of my patients, but since I do endovascular, sometimes I'm called to treat, which are delayed actually. You do your approach, you extend your approach, everything is okay, you close, and you discover a pseudoaneurysm or something because of a massive nasal bleeding afterwards. So one of the possibilities, one of the theories is that when you do extended drilling very close to the carotid and you hit it, you damage the wall with this high temperature, and actually it may lead to arterial wall pathology, with consequences will be some days later, not necessarily doing your approach. So I think these are factors that complicate a lot the life of a patient with already with a very severe disease. So if I have a patient with a severe TBI and maybe fistula, if I have the option to do adequate decompression and treat the anterior skull base through a cranial approach, I would prefer cranial approach.
Thank you so much.
Thank you very much, Professor. May I request Professor Fawad Pirzad to few comments about the Professor Yuga's talk and about endoscopic surgery, transpenoid endoscopic surgeries, the status of transpenoid endoscopic surgery in Afghanistan.
Okay, thank you very much. Thank you, Professor Yogor. It was great lecture, and it was good for education and for medical education. It was very helpful, step by step. It was great. Thank you very much, and you are very well explain all the steps, and it was especially for beginners and young neurosurgeons. It was very great. And just as I mentioned before, this the endoscopic neurosurgery and going to through nostril, it's very new in Afghanistan. And do you recommend about accompanying ENT specialist for the operation or for the dissection, and then to go to the operation theater? It's helpful, or maybe doing all but neurosurgeon? Thank you.
Thank you, Professor. Yeah, for sure, laboratory work with some dissection is a very good idea. It's difficult to find the setup because it's a different setup than for cranial neurosurgery. It means that you need to have an endoscope in the laboratory and all the instruments and etc. So, but I agree. Of course, it would be the best option is to do some lab work before, understand the anatomy, and get to the next steps. Sure.
Thank you.
Thank you very much.
Gracias.
Gracias. Yeah.
Hi, Igor.
Hi,
How are you?
how are you? Thank you
Hi,
very much.
Professor
for
Carter.
joining.
Oh, nice to see you. You're in Bogota?
No, I know you're there. I'm not there. You have a session now, right, Igor?
I have a session now.
Oh, good luck. Hello, Professor Kato.
Hi, how are you? Thank you very much for joining. So
Yes,
Igor,
Professor.
I want to ask, is there any limitation with the endoscopic through transpenoidal when you deal with pathology? Do you use the angled endoscope or
Limitations.
yeah, limitation?
Well, I think that the main limitation, number one, is just my opinion, my point of view, is that we have not yet completely understood how to do with fistulas, and mainly for the anterior skull-based approach. I think there is some progress to be done with the prevention of CSF fistulas. I think would be the point number one.
Thank you. So Ben, should we move to the second one?
Yes. May I introduce the speaker of the second lecture, Professor Kusuma Kondo. So he's the director of the Department of Neurosurgery in Sapporo Tasinkai Hospital in Japan. So today his topic would be the surgical treatment of complex MC aneurysm. So may I introduce Professor Noda for his sharing.
Yeah. Now, can I start?
Yeah.
Can you see?
Yes, I can see it.
Okay, so today I will talk about the surgical treatment of complex MC aneurysm. The presentation is not focused on this section because of the lack of time. So I would like to introduce our specialty, aneurysm treatment using revascularization. So One of big advantage of open surgery is high visibility for small vascular structure, including lenticular striate artery. Taking advantage of vascular reconstruction, high curativeness can be achieved for the complex MCA aneurysm. So our experience from 2012 to 2020, we have 420 unruptured case and 78 ruptured case. And the bypass surgery is performed in 7% in the whole, and ruptured case, we have only 9%. Okay, so aneurysm treated with a bypass are classified as complex aneurysm, and their locations are shown in the figure. So M1 trunk, 8 cases, M1-2 bifurcation, 17 cases, and M2 trunk, 2 cases. M3 and more distal is 6 cases. And let's take a look at the real case video. The patient is 47 years old female, right side M1 giant aneurysm. This is preoperative CTA. You can see the huge aneurysm in the M1, and this is preoperative schema. And from open this transcatheter vein, and you can see the internal carotid and optic nerve. And this is distal side. You can see the 6 lenticular striate artery here. So at first we made a double barrel bypass, the STMCA double barrel bypass, and secure the blood flow and put the temporary clip in the ICA and A1, and put the direct suction decompression. And you can see the A1 and the perforators. So we can put the clip here. And the ICG shows very good flow, the anterograde and the retrograde flow to the lenticular striate artery. So postoperative CTA shows very good flow of the bypass, and the patient has no deficit in the postoperative state. And this is schema. And it can be seen that anterograde flow out to the A1, and the retrograde flow from the bypass flows out to the large lenticular striate artery. Okay. This case was fortunate in that the retrograde blood flow was able to drain a short distance from the bifurcation to the larger lenticular striate artery, preventing blood flow stagnation. We are always afraid of blood flow stagnation. And one of the important technique in this case is direct suction decompression. We often use this technique in the treatment of large aneurysm, especially in MCA area. We insert a needle into the aneurysm directly and use a gel form soaked in fibrin glue to prevent blood leakage. By reducing the size of the aneurysm, we are able to keep the surrounding small vessel under direct view, allowing us to safely design the clip. Okay. We had 8 cases of M1 trunk aneurysm. The red band shows the presented case. And direct suction decompression was performed in 5 cases, as shown in blue. And this technique was very effective. Symptoms were observed in subarachnoid hemorrhage and recurrent cases, which led to poor prognosis. And one case of strong impairment, the flow out of M1 blood flow was set to narrow lenticular striate artery, resulting in stagnation of blood flow, and the cerebral infarction was happened. The lesson to be learned from this case is it is important to preserve the anterograde blood flow of M1 as much as possible, instead of using a narrow lenticular straight artery as the flow out. If you could, we have to reconstruct M1 bypass. So prevent the stagnation. And next case, the M1-2 complex aneurysm. The 59 years old male, left side M1-2 bifurcation, the complex aneurysm. You can see this is preoperative schema. Open Sylvian fissure widely and put the STA-MCA double barrel bypass and put the temporary clip on the M1, the good flow of the STA-MCA. And you can see the lenticular straight artery arising from the M1 distal. So in this time, we couldn't reconstruct M1 directly. So put the clip and preserve the inferior flow out, M1 to M2 inferior trunk flow out. This is schema. So as shown in the upper left figure, the preoperatively we planned to anastomose the ends of M1 and M2 to form a flow out of M1. However, it turned out to be difficult to preserve the lenticular straight artery in this case, as I told. So this is because when M1 and M2 are anastomosed end to end, the lenticular straight artery is sacrificed because it falls within the temporal blockage. So therefore, we decided to preserve the blood flow of M1 on the M2 superior trunk side, superior trunk side, and occlude M2 inferior trunk. So we called this modified trapping, flow out to M2 superior trunk. So trap the inferior trunk and flow out preserved to superior trunk. There were 17 cases of complex MCA M1-2 aneurysm. The red band shows the presented case. Modified trapping, I called it modified trapping. Modified trap was performed in 5 cases. In M1-2 bifurcation, M1 flow out can be easily formed by modified trapping without complicated bypass. So, except for the case of subarachnoid hemorrhage, there were no cases of worsening on symptom. Okay. And next case, this is M2 trunk complex aneurysm. The patient is 14 years female, left M2 trunk large aneurysm, and the preoperative CTA shows the very hard calcification on aneurysm. So open the Sylvian fissure widely and put the STA-MCA bypass and see the proximal side and put the temporary clip, open the aneurysm and take out the calcification and try to put the neck clipping, but it is difficult because the lenticular straight artery is included. So we put the M1, M2 end-to-end bypass, and here is the lenticular straight artery. In this case, we have to try the STA lenticular straight artery bypass to prevent the infarction. The ICG shows the little bit stagnation, but good flow to the lenticular striate artery. So post-operatively, patient has no infarction. This patient was very fortunate. So in case such calcification or thrombus is present inside aneurysm, it is necessary to clean the inside for neck clipping. Sometimes direct reconstruction of the lenticular striate artery is necessary, like in this case. In cases of fusiform aneurysm, such as this one, anterograde flow may be preserved by using radial artery graft, so interposition graft. The next case, the M1 to M3 trunk complex aneurysm. This is a 12-year-old female with multiple aneurysm from M1 to M3, like this schema. After opening the Sylvian fissure, we can confirming the structures, and here is M2 and big aneurysm. In this time, we put we made the STA MCA triple bypass in each branches of the M2 to M3. And from this is a distal side aneurysm. And isolate this one and the proximal side. Put the temporary clip and open the aneurysm and take out the thrombus. And distal, this is distal side, and this is the radial artery. So try to put the radial artery interposition graft. This is the M1 proximal side. And to end anastomosis. The important point is how to prevent the lenticular striate artery infarction. So this time we made the end-to-end anastomosis, interposition graft anastomosis to the M1 to M2, like this in this schema, shows the very good anterograde flow to preserve the lenticular striate artery. So this is postoperative schema. The proximal flow of M1 is secured to be to the M2 superior trunk through the radial artery graft. This is summary. We have only 2 cases of M2 trunk aneurysm, complex aneurysm. Both patients had very good outcome, no deficit. There were 6 cases of aneurysm of M3 and distal part of MCA. A variety of bypasses were performed, including occipital artery and STA free grafts. Because the lenticular striate artery is not involved in this part, there is little risk of cerebral infarction, and good results were obtained. In all cases, we have no complication in this area. The conclusion, the point of the complex MCA aneurysm treatment, the preserving the lenticular striate artery to make the M1 flow out is crucial. The vascular reconstruction tailored to the pathology of the lesion. So to do this kind of bypass, we have to do the daily practice, and the tactful idea is very important. Thank you very much.
Well, thanks so much. Cosmo?
Thank you very much, Professor. I don't have any words, seriously, because the first one was a basic anatomy class, and this class was one of the complex MC aneurysm. Some of the aneurysms are very, very difficult to treat, and you're not doing just one. STA triple MCA bypass plus STA lenticular site I've never seen. Never seen. It's very tough. How? My first question to you is, for a young neurosurgeon who wants to attain this bypass, STA lenticular site bypass in his life, what kind of practice does he need to have? Because I don't know what kind of practice we should be doing to have this.
Yeah, thank you for the comment. The most important thing is make the operative field bloodless, and high visuality is very important. And so approach is most important thing. And our daily practice is doing the silicon tube anastomosis in the real microscope. Yeah, we have table microscope for each. Sometimes we use it, but mainly we do the practice in the operative room, operation room.
So for the STA lenticular site bypass, how many stitches do you take? 5, 6, 7, 8. How many stitches do you take? And how do you stitch the posterior wall? Because that is the most toughest.
Yeah, that is very important thing. So the number of stitch is not so important, but in this case, I think around 6 stitches or to 8 stitches. And the backside is, as you said, it is very important. And so we always do the fish mouth trimming. Okay. So we can see the backside easily.
Okay.
Not to do like this. Fish mouth.
Okay. And may I ask, Professor, the third case you showed where there was 3 aneurysm, M1 fusiform, M2, and M3. So you did STA triple MCA bypass, and even you made sure that the M1 flow is good, so lenticular site was preserved. What was the duration of that, Professor?
You mean the radial artery graft?
Yes.
In that case, we have not so. We took long time, so around 1 hour, because we already made the STMCA triple bypass. So no concerns in the distal side. So we have to concern in the lenticular straight artery.
Okay.
So unfortunately, there is flow out, so it's okay. It was okay.
So how much of blood pressure do you maintain when you are doing such kind of bypass? What is the blood pressure do you maintain?
Depends on the preoperative blood pressure. We have to keep the blood pressure about 80% of preoperative blood pressure around. Not the exact number, but around 80%.
Thank you very much, Professor. You showed fantastic cases. I'm sure there will be many other enthusiastic young neurosurgeons who would like to ask a question. Dr. Ben is there, who's my brother. Ben, please go on.
Yes, and thank you for your lecture. It's very excellent and very nice work. So my first question is how, as a young neurosurgeon, so how the young neurosurgeon in your center train how to do the bypass? How many years, or is there any structured program in your center to train up a neurosurgeon for doing a bypass surgery? And so this is my first question. My second question is, so for those trapping surgery for the aneurysm that require trapping of the IC or proximal M1, do you think SA-MSA bypass, for example, in double barrel fashion, is enough, or you need to use a high flow bypass from the carotid artery? So how do you choose between these two? How much is enough?
Yeah, thank you for the question. In our institution, eligibility to do the bypass, to try to do the bypass, is the 20 stitches, 18 stitches less than 20 minutes. So under microscope. So we always said, so we have to make the bypass less than 20 minutes. The 20 minutes is the border. That sometimes it is difficult, but we have to try to do less than 20 minutes. So yeah, that is the answer of the first question. And the second question, when we do the trapping, so if we do the internal carotid trapping, we always do the high flow bypass in this illustration. That we always do the high flow bypass. So universal bypass theory. And we sometimes use the radial artery, mostly radial artery, but sometimes we use the saphenous graft. How to choose the saphenous graft or radial artery is there is some complex formula. We made the paper, so you can search it in PubMed.
Sure. Thank you very much. And again, your drawing is very nice. The illustration is very good. So maybe I if possible, I contact you after the seminar to get some tips from you, if you don't mind.
Yeah. Welcome. Thank you.
Yeah.
Chen?
Thank you very much. So,
Chen, please.
Anybody?
Today is very silent. Chen, please.
Yeah, it's turn to me. Thank you so much. It's so fantastic lecture, and I learned a lot. The aneurysm looks very big challenge to young neurosurgeon. And you mentioned you do the one anastomosis less than 20 minutes, right? One anastomosis mouse less than 20 minutes, or totally, because the aneurysm is very complicated. You have to do make so much anastomosis. Is the totally 20 minutes or only one anastomosis is less than 20 minutes?
Yeah, so for the STA-MCA bypass, less than 20 minutes. In the depths, the deep side bypass, sometimes it is difficult. But
yeah,
if you can do the good approach to the deep side, or you can do the less than 20 minutes. Our average time is less than 20 minutes always. Is that answer? Okay.
I mean, there is many anastomosis in the bigger challenge. The last case. Yeah. So the totally time is less than 20 minutes, or only one?
No. So the 20 minutes means the temporary clip time. If you put the when you put the temporary clip, so that the time count is start. So we have to reopen it less than 20 minutes.
Okay,
So
this is a bigger
each
challenge.
bypass.
Each bypass. So
Yeah.
when you success one pass, then you can release the claim. Then
Yes,
do
yes.
the next step. Okay. And I think it's very complicated cases. How much preparation before you do the operation?
Progression.
Yeah. Such like a homework, and you design which is the first anastomosis, which is the one the next, and the process. How do you make the preparation?
加藤先生、どういう、
多分どのようにプランニングしているかってことだと思います。手術の順序立てを。
Okay. So we emphasize in the preoperative strategy to make the strategy. So we always made this kind of illustration preoperatively. So we discuss in the morning with the CTA scan, MRI scan, the spectrography. Is that correct answer? Okay.
多分それからどういう順番で手術をやっていくかということだと思い
ます。Yeah. Basically, we have to start from the distal. Always from the distal to the proximal is a very basic strategy for us.
Okay, thank you so much. Do you do the preparation of the STA in every cases?
No.
Do you do the no?
Yeah, complex cases, only in complex cases. So around 7 to 9% of the aneurysm, MCA aneurysm, we do.
Oh, okay, I see. Thank you. And you have so much successful cases. And do you have a failure cases? And we can learn a lot more from the failure cases.
Failure case, it's not so many. It's very few. But I in my experience, I have one case in the OA pica bypass when I was young. Yeah, it is my trauma. But very few. Not so many.
Okay. After you did the failure cases, how do you overcome your psychology and how to do practice again and again in the lab?
Yeah. So again, the most important things is approach. So make it very visible and blood trace field visible and wide and shallower operative field and anastomosis. So if you make the very beautiful approach, the bypass is much easier for you, I think.
Okay, thank you. This is very important idea and key point to our young neurosurgery. Thank you so much. Thank you.
You're welcome.
So, Professor, can I ask, do you usually use the interrupted sutures or continuous suture?
Usually interrupted. Yeah. Continuous. We don't recommend continuous because when the bypass is growing larger and larger, so so it can't make it large. So if you do the continuous suturing, Yeah. So my recommendation is interrupt.
So can I ask another question? Is maybe not related to aneurysm, but for some head and neck tumor and skull-based tumor. So any experience in some skull-based bypass, for example, using the IMAX or any other artery as a graft?
So sorry, my PC is something wrong. Just a moment.
Sure.
Could you ask me again?
Yes, and so besides aneurysm, I would like to ask about the experience for the bypass in head and neck surgery and skull-based tumor. So do you do some bypass for the skull-based tumor? Any experience on using, for example, using other grafts like IMAX, internal maxillary artery, or any other special graft?
We have no experience of IMAX. We know IMAX, but I can't understand the merit of the advantage of the IMAX. Sorry, I have no experience.
No problem. And I will practice hard at home.
Thank you very much, Professor. I can see one hand raised by Dr. Bakodirjon Karimov. Doctor, can you introduce yourself and ask a question?
Excuse me, can I ask one question, please? Can you hear my voice?
It's not very clear.
Is it terrible?
No, it's not clear. So can you speak loudly, please?
Okay,
Hold
I wanted to ask one question, please. Can you hear me?
Yes.
My excuses. Lecture was very good. I am very grateful for the lecture. And I wanted to ask one question about the bypass. And we have the statement that for young neurosurgeons, it's enough to make 50 bypasses in order to get to real operations. Do you think that 50 bypass, making 50 trainings is enough for doing the real operations?
Yeah, thank you for the question. So my answer is, so it is, the number is not important. If you can do in laboratory, so less than 20 minutes in the clear operative field, I think you can try to do the bypass.
Thank you very much. The lecture was really good. I can't.
Where are you from, Dr. Karimov?
Thank you very much.
Where are you from, Dr. Karimov?
I am from Uzbekistan.
Pakistan.
Okay. Uzbekistan. Which city?
City, Tashkent.
Tashkent. Okay.
Tashkent.
Tashkent. Thank you. Thanks so much. I think maybe the 50. Yes, 50 is a good number for start, I think. Congratulations.
Thank you very much. We are training now, so being young neurosurgeons. Thank you very much.
Yeah. So, Professor Pizza?
Result is not bad for now for beginning.
What?
Results are, I want to say, results are not so bad. Under supervision of our mentors, tutors like Shavkat Aka, Rasulov, and Bishop Aka, we are doing trying to perform bypasses in Uzbekistan also.
Mm-hmm. So, Pizza, you may have some question to Noda.
Thank you, Professor Cosmo Noda. And just you told that when I was young, I say that you are still young. Don't worry. Okay, thank you very much. It was very nice presentation, and congratulations for such a good and cases and good results. It was very useful and very understanding for especially for young neurosurgeon and for neurovascular surgery. And do you have some preference for bypass, by clipping, and endovascular approaches for aneurysm? Or you prefer only for bypass? Thank you.
Yes, thank you.
So, Dr. Noda, maybe he's asking.
Okay, okay.
Yes,
Yeah.
you do the only the bypass surgery.
I have no experience in the endovascular, so I prefer to do the bypass and the clipping and the skull-base surgery for tumor. And yeah, sometimes I did mechanical thrombectomy, but no experience of coiling or stenting.
Okay, thank you.
Thank you.
Sachin?
Thank you very much. So anybody has any question at the end, or anybody just want to make any comment or say anything? Dr. Shaukat Rusalov is there from Kyrgyzstan, Dr. Rihana. Last word, anybody want to say anything before we, Dr. Liu, you want to say anything? Are you there, Liu?
Yeah, thanks, Sachin. Thanks, Professor Noda, for very nice presentation. May I ask, Professor, in what situation you will do direct anastomosis, especially for MCA? Because I saw there's some because MCA a bit long, a certain part that you can do direct anastomosis. So in what case that you do direct anastomosis without bypasses? Thank you, Prof.
So you mean the in situ bypass or?
No, end to end by resecting the cutting the aneurysm, but then you connect end to end the main vessel without any graft. Thank you, Prof.
Yeah, the most important thing is to preserve the M1 flow out. So depends on the situation. And the second thing is fusiform aneurysm. We have to resect the region. So in that case, we will perform the end-to-end anastomosis. So two reasons. One is preserving the M1 flow out. And the second thing is the fusiform or zacular.
Thank you, Prof.
So
Thank you very much, Professor.
Finally, just I want to ask how you can decide double bypass is enough for the ischemic the time. How you can evaluate?
Yeah. So the last case, we have no connection in each M3 region, so we have to do the 3 bypass. But if there is a connection, the two barrel is good enough, and only one M2 area, so like the super trunk of M2, we need only one STM bypass is good enough.
Okay, thank you.
Do you have any experience on aneurysmography, where instead of clipping, they suture the walls of the aneurysm? Aneurysmography.
Wrapping?
Aneurysmography, where suturing the aneurysm.
Yeah. We do a lot of time. So suturing neck or rupture point, something. So control the bleeding.
Okay. Thank you very much, Professor. So if nobody has anything to say, then I would, before Professor Kato says the final word, I will like to say that it was a wonderful session today. We had Professor Eager, who had showed us the what are the possibilities of exploring the anatomy of the nose and the possibility of it to be one of the best neurosurgical corridor on the conjunctival dissection. Surgery you can have ever seen in your lifetime by Professor Kosumo Nada. Few wonderful cases and wonderful dissection and phenomenal cases. And I would like to thank my co-moderator, Dr. Ben, Dr. Chen, and Dr. Rihanna for being there and supporting me, and Professor Fawad Firzad for having with us as a chairperson. Very happy to see you, Professor Fawad. And of course, my brother, Dr. Liu, for the constant support. May I request Professor Yoko Kato to say final words before we close the session, Professor?
Yeah,
it was our first webinar of this year.
Yeah.
So now.
So this is the real first time of this year, and maybe the Sachin will make announcement of the next one. But first of all, just we are so happy to see the Dr. Firzad, the smiling face, because you are so safe and healthy. And we congratulate to you. And also today's two webinar is very basic things. One is anatomy, and the second one is bypass surgery. The bypass surgery is very fundamental for the YNS, I think. Maybe you can ask details about how the practice, daily practice. He said just daily practice. But the daily practice means what it is. So just you can ask by email, I think. That is the most important things. So once you can do the bypass surgery, maybe that you are not afraid. Once it's the premature rupture, something like that, something happening during surgery. Another the weapon, I think, as a neurosurgeon. So both the lectures were so nice today. Thank you for organizing, Dr. Sachin and Dr. Liu. Thank you very much. And I'm so happy again the beautiful Chen face. Thank you so much. Ben.
Thank you. So before we close, I would like to make the last announcement of our first World Young Neurosurgeon Congress. So on 6th, 7th, and 8th of May, we are going to have a first World Young Neurosurgeon Congress webinar, a 3-day webinar dedicated for the Young Neurosurgeon Congress, full of hands-on virtual workshops. There'll be 5 virtual workshops. There'll be interactive sessions and YNS award session. And Professor Yoko Kato has said that whoever will be the top 3 YNS awardees will get $1,000 US, a chance to have a free publication in Asian Journal of Neurosurgery, which is the official journal of ACNS, and to be the member of ACNS-YNS committee. So I would request you all to kindly share this information with your friends and your colleagues and ask them to kindly send us more and more abstract for our conference. thank you very much. And please, I wish you all a great health and success, but please kindly contribute to our Congress. Thank you.
Sachin, when is the next time?
So next time will be next 27th of March. 27th of March.
27th. Okay. Start 7 Sachi. Okay.
Yes,
Ben?
same time, 7 time.
Ben, thank you so much.
Yeah, you're welcome, Professor.
Thank you very much.
See you next time, please. Yes.
Thank you. Arigato gozaimasu.
Next time.
Dr. Sachin, could Afghanistan young neurosurgeon also participate and present some cases and apply for awards as well or not?
Of course.
Yes, of course.
Yeah.
Definitely, please.
Okay, please share the link, yes?
Just send the papers.
Okay, okay. Thank you very much. Thank you, Professor Igor, Noda, and all colleagues, Dr. Sachin, Professor Kato, for supporting Afghanistan people through supporting Afghanistan neurosurgery, especially young neurosurgeons. Thank you very much. Arigato gozaimasu. Shukriya.
Thank you. Thank you very much. Okay.
Gracias.
So see you next time. Bye.
Okay. Thank you.
Bye. Thank you so much.
See you next
Arigatou
time.
gozaimasu.
Bye, arigato.
Oyasumi.
Arigato.
Nice to meet you. ありがとう。
先生、ありがとうございました。
ありがとうございます。こそ。